Good morning, everyone, and welcome. I know many. I'm Michael Doyle, and I'll be moderating the medical panel today. So we're going to back up a little bit now and talk about the safest and best and most ethical practices medically to create those babies. Put on your seatbelts. We're about to start a crash course in the medical aspects of reproductive medicine. We have 5 world-class speakers that are going to cover the topics of screening and selecting egg donors, surrogates, the tests that you need to go through, the medical approach, things that go on in the IVF laboratory, and finally issues related to embryo transfer and early pregnancy. Our first speaker is Dr. John Norian, who's going to speak about the aspects related to choosing and selecting and screening your egg donor.
Thanks so much for the introduction. Right now I wanted to spend some time speaking about egg donation and what are the optimal ways where we can identify the best donors for each of us. So what are some of the characteristics that we look at when we're selecting an optimal donor? First and foremost, we want to know the age of the donor. Ideally, egg donors will be between 20 and 30 years old. We want them themselves to be healthy, and we want their family history to be basically healthy. And when I say that, I mean it's okay if a person's grandparents or grandfather has a little bit of elevated blood pressure or a little bit of diabetes, but overall we don't want a strong family history of, let's say, early cardiac disease or early stroke. That's hugely important. We also learn a lot of factors about their personality. We learn their hair color, their eye color. Many of the different egg donor agencies, there'll be a variety of pictures of the donors. We'll see them when they were an infant, and even now we see them when they're in secondary school, in high school, or college. Their personality, they write essays. Egg donors are such kind women who really want to have a little more of a lasting impact in this world. And what better way to help add to a person's family by donating their eggs? They write essays. They describe, are they more mathematical? Are they more artistic? Oftentimes you learn what's their favorite movie, what's their favorite book. They're very genuine people. I will say that certain agencies or certain people may focus a little more on education level and things like that. And me as a provider, I put less emphasis on that in the sense that, you know, the whole nature versus nurture thing. Really, I want a healthy donor with a good family history. And then many of the other personality traits are up to the future dads. Why is age so important when we're looking at egg donors? And the reason is that when we look at human fertility, when we look at female fertility throughout the ages, even going back to the 1600s France, we know that women, as time goes on, our fertility will decline as humans. So peak human fertility is before the ages of 33, 32, things like that. Now remember, other families, especially other women who are older, still have the opportunity of adding to their families, Janet Jackson being one, who had a child in her mid or late 40s. And those women often will use egg donors even when they're in their 40s. I'm sorry this slide isn't as readable, but as time goes on, egg donors can even help women who are older. Why does this happen? So this happens because our egg quality will decline as humans age, as females age. And you see here, I know this is a little bit of a busy slide, but as time goes on, women over 42 years of age, only 15% of their embryos are chromosomally normal when we do chromosomal screening of the embryos. Whereas egg donors, 2/3 of them are normal, which even myself find a little bit amazing. Other species will have an even higher pregnancy rate. Humans, 2 heterosexual couples having intercourse regularly, 2 25-year-olds, not everyone gets pregnant each month. And part of the reason is the egg is not just a good egg, even in our peak humans, in our young donors. So getting back to screening egg donors, what are the steps? How do we do it? So first and foremost, we do medical clearance. That's where an egg donor will meet with someone like myself or the other physicians on the panel, and we'll take a thorough history and do an examination, where typically that will include an ultrasound, where we can assess a woman's ovarian testing or ovarian function. Of course, we do infectious disease screening. We want to make sure she doesn't have any infectious diseases such as gonorrhea, chlamydia, syphilis, HIV. A genetic clearance is done, and that often involves a blood test or saliva test. And many times we'll take a detailed family history, and that may involve a genetic counselor. Psychological clearance is done. I think we heard a little bit about that yesterday. Reproductive specialists focus on this area to make sure that a woman is of good sound mind. A standardized psychological assessment or exam is done, and we want to make sure there's no coercion or anything along those lines. And then lastly is legal. Remember, these eggs become your eggs. These embryos become your embryos. There are some unique features, especially with the disposition of the embryos as you are finished with your family building, where the legal contract can really assist with spelling that out. So medically, what do doctors look at when we are trying to assess a woman's ovarian function? So first and foremost is doing an ultrasound and is counting their follicle counts. You see these little black spots? These little black spots are what we call follicles. These are where the eggs live. There's one egg per follicle. Ideally, a general woman will have greater than 12 resting follicles on her ovaries. For egg donors, we like that number to be even higher. We like that number to be greater than 15 to 20, particularly if there's two dads where we have two sperm sources. We want to make sure that we've got a good, strong ovarian function where we'll be able to get a good number of mature, healthy eggs. Another way to assess a woman's fertility is by doing a simple blood test, an AMH level, or an anti-Müllerian hormone level. That's what I would say is part of a fertility checkup, a follicle count and an AMH level. Ideally, we want that level to be greater than 1.5 in general women, but in egg donors, we want that number that bit higher, especially if we have two sperm sources. Genetics. All right, so with technology, we're able to screen a person for over 200 inherited silent conditions. Remember, being human, we all carry silent disease, whether it's a thalassemia, whether it's cystic fibrosis. You can't just go based solely on a person's ethnic background. And using these very low-cost tests, we're able to screen each of you for any inherited conditions and also make sure that your donor doesn't carry the same mutation. Prior to pregnancy is an ideal time to do this assessment. Like I was mentioning, a thorough family history, especially working with a genetic counselor. We can do 3-generation medical pedigrees and screening for things like early heart disease, type 1 diabetes. Things like this are hugely important and are things that we would want to avoid in an ideal donor. All right, so let's spend a little time just chatting about known versus anonymous donors. What does all this mean? So historically, many of us had used anonymous donors where we only learn information through the website and we get donor profiles through different agencies. Like I was describing, they write essays and things like that. It's a very useful tool. But now we're also able, with many agencies and many different channels, able to get some level of communication, whether that's a video call, whether that's an in-person meeting where you might meet for a coffee at Starbucks or your preferred coffee house, I guess. And some can be even more open, where the donor is comfortable with staying in contact throughout her lifetime. A known donor, which is really rewarding, often can come up where we might use a person's family member. If we have two future dads, we may use the sister of one dad and the sperm of the other. And that often involves a friend or a close family member. Please do remember that we still need to obtain all the appropriate clearances, the FDA labs, the infectious screening labs, legal clearance, psychological assessment, all that is still done with a known donor. Now remember, there are many other vehicles where we can learn more about the donor in the future. And that's through well-designed, well-meaning registries, where many times an 18-year-old child doesn't necessarily wants to just check in with the donor and make sure that she didn't get any weird medical disease or weird genetic disease. But they really don't want to, remember, the child, you're still the dads, you're still the parents, but sometimes they just want to have an idea about their biological donor. One comment, are any of us truly anonymous? Especially in this age of 23andMe, DNA kits, facial recognition software. Oh my gosh, last night I was talking to a gentleman about privacy. So this concept of anonymity, say that 10 times fast, in 2018 is really much different than what it was 20 years ago. So for this, we clearly need more coffee and more time to talk about. Proven versus first time, just to quickly comment on. Proven donors often have had a prior successful pregnancy. We have a much better idea as reproductive specialists how many eggs that we anticipate to be retrieved. This is especially important when we've got two sperm sources. Remember, not all the eggs that I retrieve are going to be mature. This is a beautiful, healthy, mature egg here. And not all the mature eggs will fertilize. Not all of them will develop into a beautiful implantation stage embryo. So if we have two sperm sources, this feature is that bit more important, especially if a person is using PGS or pre-implantation genetic screening, or would like a boy or a girl for sex selection. These are also things where a proven donor may be more useful. However, first-time donors are often new but noteworthy. They can be more affordable, and but that being said, there is a risk of them having a slightly lower response. So that's where having a perfectly compulsive doctor that's assessing their ovarian function with follicle counts, AMH levels, is hugely important if you work with a new donor. Fresh versus frozen eggs. In 2008, 2009, there was a big leap in technology where we learned to snap freeze or vitrify eggs, where we could thaw them very reliably with high survival rates. The technology appears safe, but the long-term data is limited. When you're working with egg banks, remember you typically only receive 6 to 8 oocytes, 6 to 8 eggs. And oftentimes, the egg banks will guarantee at least 1 or 2 embryos suitable for implantation, but there often is not extra embryos that are ready for cryopreservation or for freezing. This is another option that's more affordable, and it's ideal if a couple would just like to have a single pregnancy. Fresh eggs are often more optimal. They give us more to work with. And especially if there's a desire for siblings, or if we're using chromosome screening where we're checking if there are 46 chromosomes, or let's say one of you were to have a rare disease and we need to do PGD or genetic diagnosis for unique disease, that would be more of an indication to think about using fresh eggs. And remember, with science and with different social media things, I often hashtag science matters. It's so lucky, we're so fortunate that we live now, where we have tools such as vitrification, we have tools such as assisted reproduction to help add to your family units. So with that, I hope that was a little more useful information, and thank you for listening. All the best.
Thank you. I want to add, we do have time for questions and answers at the end of the last panelist discussion, so keep them in mind and we will get to them. Our next speaker is Dr. Jerald Goldstein from Fertility Specialists of Texas, who's going to talk about the selection and screening tests that are relevant to a gestational carrier and to each of you prior to going ahead with the IVF process.
Hello, welcome. I've been tasked to go over a few topics regarding surrogacy. And this is just, in general, I'm going to talk a little bit about how gestational carriers are recruited, the screening of surrogates, talk a little bit about agency versus independent matches, the processes in terms of sperm collection, and also options for HIV positive couples. So in general, in terms of recruitment of surrogates, and obviously there are a lot of surrogate agencies here, so they could speak to it much better than I can, but in general, it's, that the recruitment is through, if you have a surrogate, for example, if there are surrogates that are good surrogates, then they ask if they have friends that are interested in being surrogates, word of mouth, Facebook groups, talking to other carriers, and then obviously, they're independent. They're surrogates that are through independent matching. I would say, and I truly believe this, especially if it's your first journey, that oftentimes it could be tempting to do an independent journey, so to speak, and you may think that you're at times saving money by doing that, but certainly based on what I've seen in the long term, and it can be very, very expensive. It's a very daunting process, going through it a lot, and so it's often very helpful to have someone to help negotiate the process for you, and certainly it certainly makes it much more seamless. So. Should you use an agency or try an independent match? Obviously, when you're using an agency, agencies have a lot of experience. They've been there, done that before. They've pre-screened the surrogates initially, even before the surrogate. Oftentimes, the agency will initially do a screening, but then they'll send the records to the surrogate to the fertility doctor to look at, to say, okay, are you okay with this surrogate? Certainly, like I was saying, when you're using an agency, they're able to help walk you through the process, and it makes it much more seamless, and certainly makes much less anxiety-provoking. They coordinate logistical issues. There's a lot of issues that come up oftentimes when you say, well, it's pretty straightforward. You take sperm, and you fertilize eggs, and make embryos, and then transfer in a surrogate, and it takes 20 seconds to say that, but the process itself is obviously much more involved, and so having an agency can be very helpful in that regard. Agencies can act as an intermediary between you and the surrogate. The surrogate, it's not like an egg donor where you find an egg donor and you see her picture and you go through and you create embryos, and then that relationship, depending on how it's set up, is over with. The surrogate is someone that's going to be carrying your child, and so the relationship can be very, very important, certainly to you and also to the surrogate as well. When you're using an agency, obviously there's a matching fee, but as opposed to when you do an independent match, that's where oftentimes people can feel like that they are perhaps saving in that regard. But at least from my experience, oftentimes, certainly the first time when you're going through that, it ends up it can be more expensive in the long run. Independent, using it, if you're doing an independent match, obviously you don't have necessarily the experience that that they are. Initial screening is often at their first visit, as opposed to pre-screening before. The learning curve can be very steep. you end up, you can do arranging and coordinating a lot of the issues that typically is involved. That's done by the surrogacy agency, and but obviously then there's the matching fee. So once a surrogate is selected, oftentimes that you'll be sent profiles, perhaps have like a Skype visit with the surrogate before you actually meet the surrogate in person, and then when the surrogate comes to see us, we're a fertility clinic, then we also do subsequent screenings. Surrogates in general are, you do have a desire to become to help other people be parents that otherwise would not be able to. They typically have uncomplicated pregnancy history. Their BMI less than 35, so they're not overly overweight. Typically, they should not have more than 5 total deliveries, or certainly more than 3 C-sections. Although, depending on the case, there can be, these aren't strict guidelines. Typically, age less than 40. Certainly we do, and have like the OBGYN, the person that's actually going to be taking care of the surrogate. So after they go through and you do an embryo transfer and you do a couple of ultrasounds and document the number, cardiac motion, then they're sent to the OBGYN who's actually doing the delivery. So usually we'll get a letter from the OBGYN before they go through saying that he's familiar with the surrogate, and he agrees to take care of her, or she agrees to take care of her, and we have that's part of the screening process. Surrogates have a drug screen. They have a toxicology screening when they come in, and also sometimes that from the agency, for example, usually they'll do a background check, and so they're screened very well. So when surrogates come to the office, and oftentimes depending on how things are set up, sometimes they'll end up meeting the intended parents like the night before when they come for the first time, initial time, and to the office. Then they'll come in and we'll basically sit down and go through the process with the surrogate of the medical process. And she'll have a physical exam. She'll have an ultrasound. The ultrasound is different than what we were talking about before. In other words, instead of looking at the ovaries and looking at the antral follicle count, we're really not interested in that. We're interested in the uterus, basically the house and the ability to carry a pregnancy safely to term. So we look very carefully at the uterus. They'll have a special study where you can actually look inside the uterus, where you can put fluid in and you can get a very detailed picture inside the uterus, looking for any sort of issues that may increase a risk, for example, of delivering early. They have infectious disease testing, and then they'll have the medical instructions. What about sperm collections? The sperm collection, obviously, on your initial visit, you'll come in and meet the physician, go through the process. They'll typically have a semen analysis, and then we freeze the sperm. At that time, in the States, it's regulated by the FDA. There's a special questionnaire, and you'll have to have a brief exam. Typical semen analysis is, concentration over 15 million sperm. So. It's very unusual to have a male where there's an issue where you're not able to really use their sperm, even if their motility happens to be low or their morphology is low. Typically, at least in our program, when you're freezing sperm, we usually use ICSI, where you physically inject the sperm inside of the egg to allow fertilization to occur. Literally, it's like I've been doing this for 20 years, and it's like amazing to me that you take sperm and look at it under a microscope, and they're like running around like crazy. I mean, it's crazy, and so. All it takes, obviously, is just a single sperm to fertilize an egg, but it's the whole process of making a baby is really amazing. Last thing is in terms of options for HIV positive men. Obviously, now that that HIV is the treatments are very, very good, and so now in terms of reproduction, there are certain. There's, for example, in the States, that there is a foundation in Boston called the Bedford Foundation, where basically that you're able to minimize to zero, basically, the risk of transmitting the virus in the course of pregnancy. That involves having sperm that is tested through a special molecular process called real-time PCR, where you're able to detect viral loads. So even if you, for example, men that have a viral load of 0 still can have the HIV virus in the seminal fluid, which is the fluid around the sperm. So you're able to test that and make sure that there's no HIV virus around the sperm itself. And so typically that's done in Boston. It's through an IRB sort of protocol, so it's very safe, but it's under a certain protocol. And then either collecting there, oftentimes can go there to collect, or at the clinic itself. And then once they're able to guarantee that there's no virus in the sperm itself, they'll send it to the clinic, and then that sperm is obviously used for to make a baby. So it's definitely a very much viable option, and there's been no instances of transmitting HIV through that process, or through IVF as well, even if you people that have not actually done that. But it's very, it definitely is a good option for men that have HIV. Anyways, hope that if y'all have any other questions, obviously we can talk later on, and thank you.
Okay, our next speaker is Dr. Brian Bankowski from Oregon Reproductive Medicine, and he is going to walk us through the medical steps in a egg donation surrogacy cycle.
Is this working? No. Okay, we'll talk from here. I have trouble standing still when I talk, so I like to be mobile, but I'll do my best.
Hello?
The mic, the last one worked? This one worked? This one? Thank you. Okay. So I've been given 8 questions and 8 minutes, so we're going to go fairly quickly. The most important thing that I want you to remember from this entire talk is that this is a human process, okay? It's a human process. This is very difficult for computer engineers to deal with because they expect to push a button and get a result. And in a human process, it doesn't necessarily happen that way. The first question that I'm going to talk to you about is medications. Discuss the medications that are used, how they're monitored for the donor and the surrogate. The point of the medications that we use is that we make a safe process and a more successful process. The main medication used for egg donors is intended to increase the number of eggs that grow. A woman every month recruits a group of eggs. That's determined by her age and her genetics. A donor in her 20s often will recruit 20 or 30 eggs. But in the natural process, her brain sends down just a small amount of fuel so that only one of those eggs grows to maturity. That's why women usually ovulate 1 egg and have 1 baby. But only about 7% of eggs turn into babies. So to make this more successful, what we do is we give her more of that medicine. That medicine is called FSH, or follicle stimulating hormone. This helps a lot of the eggs to grow so that we can collect a number of them. We have the ability to monitor these by measuring the estrogen and the progesterone levels in the blood, and by doing ultrasounds to watch the follicles grow, as you saw on Dr. Norian's slides. One of the rare things that we do worry about is an overstimulation called OHSS. This happens in modern protocols about 1% of the time. In surrogates, our goal is to take control of the process. We want the uterus to respond as it does in the normal sense, but we don't want a surrogate to ovulate her own eggs. So we first take control with some special medicines to suppress her own ovulation, and then we use estrogen and progesterone to build up the lining and monitor that again with ultrasound and blood work. The timing. The timing is very important because the tissues are responding in an orderly and a predictable way, and the hour that you do the transfer and the hour that you do the egg collection are very important to the success of the process. And so this has been studied very well for 40 years, both in fresh cycles and in frozen transfers. We give medications in a very specific way. And what's important about that for both the donor and the surrogate is that they understand what they're supposed to do, because they're doing most of these medicines on their own. And so we spend a great deal of time with our teams teaching them and being available to them so that they know what to do. It's actually very complicated. When I did my own IVF cycle, I had to look something up on the internet. My wife doesn't let that go to this day. The egg collection. The egg collection is a very brief procedure. It's not really a surgery. There are no scalpels. There are no incisions. It's done with an ultrasound and a needle, and it's done under anesthesia. It takes us probably 10 to 20 minutes in total to collect all of the eggs. The point of the anesthesia is so that for two things. Number one, we don't want the donor to experience any pain. And number two, we don't want her to move during the process because it makes it a lot more difficult. In most cases, the anesthesia is given so that the donor is breathing on her own, and as soon as you turn that medication off, the donors wake up. The main risk of this process is that you can have bleeding from the egg collection procedure, from the retrieval. That bleeding usually happens that day. Luckily, it's on the rate of about 1 out of 1,000 cases. And very rarely we have to take an egg donor to surgery after that. The number of eggs collected. Dr. Norian talked a little bit about the number of eggs, but if you aggressively stimulate a donor, we often get between 20 and 30 eggs. And you might be like, well, we don't want 20 babies. Why do we need so many eggs? But it doesn't work like that. It's a pyramid. It starts out high and it goes down. If we get 20 eggs, about 3 out of 4 of those are going to be mature or useful. About 3 out of 4 of those will successfully fertilize. Those are single cell embryos. And then about half of those will grow to the stage at which they're ready to implant. Those are often day 5 embryos. We call them blastocysts. Now, only 2/3 of those will be chromosomally normal or have normal genetics, and only a certain proportion of those will make babies. And so that's why we use these medicines to get a lot of eggs so that we can have a good number, especially if the eggs are being split between 2 sperm providers. One thing that is important to know for your expectations, again, it's a human process. Egg donors sometimes go through multiple cycles with us. Same donor in the same year, taking the same exact medications, you can often see 50% decrease or increase in the response from 1 month to the next. It's a human process. The timing of the transfers, I actually looked this up to give you the right data. In the 2016 data, 60% of all US transfers were done at day 5, and then another 30% or so at day 3. I think from speaking to my colleagues in the modern practice, there's much more day 5s, probably more like 90%. And a part of that is because of improvements in the ability to grow the embryos. And in most cases, genetic testing of the embryos requires them to be at day 5 to do it safely. So actually, in my practice, all of our transfers are day 5 or day 6. We don't do any day 3s. And then the last thing is on repeated implantation failure. This means that if you put embryos back and you don't have success, you put them back again, you don't have success, over and over. There are entire conferences that are devoted to this question, and I have 60 seconds to answer it, so I'm unfortunately gonna shortchange you in the answer, but 2 things to think about. One would be, well, perhaps there is a genetic condition in the donor or in the fathers that we're not aware of. So perhaps there's some extra genetic testing. Perhaps you should consider doing comprehensive chromosome screening, or PGS or PGTA, which all means the same thing, to test the embryos to see if they're normal. And then sometimes we'll talk about transferring into a different surrogate. Of course, as you establish a connection with a surrogate, that's a big deal to change surrogates. And so surrogates have already successfully had live births. And so it's fairly rare, but if you do 2 or 3 or 4 transfers, depending on the clinic, depending on the circumstances, depending on your desires, at some point we think about changing into a different surrogate. So thank you very much. I'm happy to answer questions later.
Thank you. Okay, our next speaker is Dr. Saeed Daneshmand from the Platinum sponsor San Diego Fertility Center, who's going to take us into the IVF laboratory and walk us through the steps involved in embryo creation and embryo selection. Dr. Daneshmand.
Terrific. Well, I have 3 teenage daughters. I don't have any grandchildren yet because I'm still a young man. So much unlike Steve Snyder. So I'm Dr. Saeed Daneshmand. What I wanted to talk to you about today was mainly about how do we select embryos for transfer. When we create your embryos, and typically what we do is we freeze the embryos because there's no difference between fresh and frozen pregnancy rates. What we decide as physicians, as doctors, is we decide which embryos are the highest quality embryos that are going to be associated with the healthiest pregnancies. So I wanted to give you a little bit of an insight into the lab in terms of what happens when we thaw embryos and how do we assess the quality of embryos. So what ends up happening, as Dr. Norian said, is that once we retrieve the eggs, the first part of the process is the fertilization, which you see right here. And you have two nuclei, one from the male, one from the female, and we assess, and typically about 70% of the eggs that we retrieve are actually fertilized and start developing. There are 2 ways in which we can assess the quality of embryos. One is by studying them under the microscope and assessing the embryo quality or the structural quality of the cells. And this is something that we have published papers on. And the other way to do it is through genetic analysis or through pre-implantation genetic diagnosis or screening. So let's talk about initially how we assess the embryos under the microscope. So after the embryos are fertilized, after the eggs are fertilized, what ends up happening is the embryo starts dividing into 2 cells, into 4, into 16, all the way to a stage called a blastocyst. And before the embryo implants or attaches to the lining of the uterus, it actually has to hatch out of its shell. So here you actually see an embryo coming out of its shell in order to be able to attach to the lining of the uterus. And typically what we want to do is by the time the embryo hatches out, we really want to have the embryo back into the uterus. And so sometimes we end up wanting to make sure that we get the transfer done right before or right at the time when the embryo is hatching. So how do we assess the structural quality of an embryo? Well, there are 2 different portions of the embryo that we assess under the microscope. One part is called the inner cell mass. It's these group of cells that actually give rise to the fetus, to the baby. And what we look for is we look at the diameter of the inner cell mass. We look to see how cohesive and how compacted the cells are. Then the second group of cells are the trophectoderm. So these are all the cells that are outside the inner cell mass. And what we do is, again, we assess the diameter of the embryo. We look at these individual cells, and we actually count the individual cells on a cross-sectional basis. And we actually look at the diameter of these individual cells. And again, that combined with the inner cell mass gives us an idea as to what the quality of the embryos are. Now, clinics have different grading systems or different sort of assessment. Sometimes they'll say an embryo is quality A, B, or C, grade 1, 2, or 3, or they'll say AA, AB. It can be confusing, but the best thing for you to do is once your embryos are created, make sure you have a consultation with your doctor, and all of us do consultations after embryo creation so that we can explain to you in detail which embryo we're going to transfer and what are we basing that assessment on. So as we talked about, embryos can be graded based on their appearance, but there are many features of an embryo that we can't assess under the microscope. Sometimes embryos can look good quality, but they may be genetically abnormal. So the next potential test that we can perform is something called PGS. that will test the chromosome or the chromosome numbers. As you know, we're going to have 23 for an embryo. 23 chromosomes come from the egg and 23 come from the sperm to make a total of 46. So when we do PGS, what we're really doing is we're counting the chromosomes. We're assessing the chromosomes, making sure that all the chromosomes are paired up from chromosome 1 all the way to chromosome 23. So for example, when you have, instead of having one pair of chromosome or 2 chromosomes, you have 3, and it happens to be on chromosome 21, we call that trisomy 21 or Down syndrome. Most of those embryos in nature stop developing after a certain point, but a very, very small percentage can make it to a pregnancy and are not discovered until later on. So that's the sort of the theory behind it. And so what is PGS? As Dr. Bankowski mentioned, we would like the embryos to develop all the way to blastocyst before we take the cells out and before we do a biopsy in order to cause the least harm to the embryo. If we did the biopsy when the embryo was only 4 or 8 cells, that could cause more harm to the embryo and potentially cause the embryo to stop developing. Now remember, any harm from PGS or biopsy doesn't mean we're going to have an abnormal fetus or abnormal baby. It just means that we're going to lose that embryo. And even when we do it at the blastocyst stage, there's still a possibility, about 10%, that some embryos are fragile and can stop developing. Therefore, PGS is performed in selected cases. We don't recommend PGS in every case, but we do recommend it in selective cases. And this is, again, a very important discussion for you to have with your doctor prior to starting the IVF cycle. And really, you should have a plan for PGS or no PGS before the donor starts their sort of journey through the IVF stimulation and before the eggs are retrieved. And the reason for that is because the laboratory has to be ready. So the way the biopsy is done, we create a little bit of a hole in the embryo's shell, and then we extract or biopsy about 3 to 4 cells, and then we send it to a genetic. So you can actually see here the biopsy being done in our lab. There's the embryo right there. So then what we do is essentially biopsy these cells from the embryo, and now the biopsy's done. Now you say, well, this looks invasive. You know, what happens to the embryo? The embryo actually is very, it's very strong. So most embryos after this biopsy will just go back to developing. And typically what we do is after the biopsy, we freeze the embryo. We don't want to do a fresh embryo transfer. And the reason is because most of the time it takes us about 24 hours before we get the results for the PGS. And so we don't want that embryo that's just been biopsied where we created a hole in the embryo. We just don't want that embryo to just stay in culture. We want it to either we freeze it or we want to have an embryo that's transferred. So we always do a freeze when we do a biopsy. We don't do a fresh embryo transfer. We have done studies and publications on embryos, frozen embryos and fresh, and when we do PGS, the rate of pregnancy is going to be lower if we do a fresh embryo transfer. The other issue is, remember that your surrogate's uterus is getting prepared at the same time when we're preparing the embryos. The uterus of the surrogate is only open to implantation, only that we have that window of implantation. So it's only ready for implantation during a very specific time period. And if the embryo is not transferred during that specific time period, no matter what kind of quality the embryo is, it's not going to implant into the uterus. So in other words, we need to synchronize the uterus with the embryo. And again, we can do that by freezing the embryo, and then once the surrogate's uterus is ready, we thaw the normal embryo and we transfer back into the uterus. Then what we do is we do sort of an analysis. This is sort of a graph of the next generation sequencing. So we're actually sequencing the DNA. And then this is one of the famous doctors doing a transfer. So now, if you don't do the PGS, what can you do in order to find out the presence of chromosomal abnormalities? Now remember that if the pregnancy makes it to 10 weeks of gestation, the odds of having a chromosomally abnormal fetus is less than 1%. So the risk of chromosomal abnormalities is always dependent on the age of the egg donor. So if you're using an egg donor, let's say a friend who's 37 or 38 years of age, PGS is definitely recommended. If you have a young egg donor that's 24 or 25, the risk of chromosomal abnormalities is very low. We can do the PGS, but it's certainly a discussion that we want to have. The other indications for PGS are sometimes when we have sperm abnormalities. The sperm can transmit abnormal chromosomes to the embryo. So for severe sperm abnormalities, that's another instance where we sometimes recommend PGS. Or we look at your genetic history, and if there's anything that concerns us, we will then talk about either PGS or something called PGD, because these cells that we take out can also be analyzed for genetic mutations, such as mucoviscidosis, hemophilia, thalassemia. So as I said, constant communication with your physician and with your doctor is really critical. If we don't do the PGS, once the pregnancy gets to about 9 to 10 weeks, we can do a blood test on your surrogate, a test called the non-invasive prenatal test, NIPT. There are many companies that do that, and it's a non-invasive blood test and fairly accurate, over 90%, and that'll tell us the presence of any chromosomal abnormalities. It's very important for all of you to have the same philosophy in regards to the interruption or termination of pregnancy as your surrogate. So just in case, because not only are there abnormalities with chromosomes that are dependent on the age of the egg, but once the pregnancy develops, there could be malformations. The rate is somewhere around 1 to 2%, and sometimes those malformations can have a significant impact on the health of children. So again, having that discussion and having the same philosophy as your children, as your surrogate, is really key to this whole journey. Thank you so much.
Thank you. And our final medical expert today is Dr. Guy Ringler from California Fertility Partners, who's going to walk us through strategies to ensure a successful embryo transfer and early pregnancy. Dr. Ringler.
So this is our goal, a healthy baby born at term. So far we've heard about how to screen our egg donors, how to screen the surrogate, how to stimulate the egg donors, how to create embryos. So now it leads up to the critical step of how do we do the embryo transfer. But just to review, some of the factors affecting the IVF success rates include the quality of the egg. All the egg donors are young, so in general, young women have high quality eggs that should produce high quality embryos. Sperm quality. When I initially meet with my intended parents, we always talk about sperm counts, and if you guys haven't had a semen analysis yet, I highly recommend it, because if there is a sperm problem, we want to know about it and see what we can do to help improve your sperm count, improve your sperm quality. The ovarian stimulation, how we treat the donor, how we monitor her when we remove those eggs has an impact on the egg quality. She's young, but if you can literally overcook the eggs and decrease their quality if your timing of your egg retrieval is off. The IVF laboratory is very important, and that includes not only the physical plant, but the embryologists that work in the laboratory. I've learned this firsthand. 2 years ago, we built a brand new IVF lab with state-of-the-art equipment, purified air system. We have a new IVF lab director, and over the last year and a half, we've seen a significant improvement in our embryo quality and our success rates. So be sure to ask who's behind the laboratory door when you're talking to different programs. Uterine factors, the surrogates are very carefully screened, because what we're looking for is someone who's going to provide this ideal environment for getting pregnant and for carrying that pregnancy to term. And that's what your surrogate should provide you. And lastly, the critical step, the embryo transfer. We take all this energy creating these perfect embryos, and so we have to be very careful how we place these into the surrogate's uterus. Now, if you look at it in a diagram, it looks pretty simple. So this is a uterus, and the embryo transfer catheter is a very thin plastic tubing. It's like a piece of angel hair pasta, thin, pliable piece of plastic. And what we do What we do is we pass it through the cervix into the uterine cavity, and we're going to release the embryo in a tiny drop of fluid. And we're going to do that under ultrasound guidance so we can see exactly where the catheter is going, so we know where the embryo is going to land within the uterine cavity. So catheter's placement is important. The experience and the skill of the person doing the transfer is very important. There have been studies within individual IVF programs. There's different pregnancy rates according to different practitioners, according how they put in the embryo, their skill at this, what looks like a rather simple technique. For years, we put patients on bed rest after the embryo transfer. We thought, oh gee, it's really important, they can't move, the embryo might come out. Not anymore. Patients get up immediately after. Studies have shown that bed rest does not impact pregnancy rates. So you don't have to have your surrogate glued to that bed for 48 hours like we used to do. Now, what about fresh versus frozen embryos? So this is a very interesting question, and with some interesting, complex answers. So to look at this, I looked at SART data. SART stands for Society of Assisted Reproductive Technology. So basically, this is a data bank. It's a summary from all the IVF programs in the United States. And this is from 2015. This is the most recent year when all the data has been reported. And this looks at live birth rates from fresh embryos compared to frozen embryos using egg donors and surrogates, okay? Now you look at the numbers, fresh was 58.9%, 52.5%. To me, that looked pretty similar, but actually I was surprised if you do statistics, fresh had a slightly higher significance in terms of pregnancy rates. Now this can vary from program to program, in large part, I believe, due to the experience in the laboratory in freezing and thawing embryos. I know in our program, our pregnancy rates are the same, fresh versus frozen. So when you're interviewing different clinics, ask about their experience. 10 years ago, we would all do fresh embryo transfers. 10 years ago, all of our pregnancy rates with fresh were higher than frozen. Today, we do frozen transfers in 98% of our cycles, and the pregnancy rates are the same. How many embryos do we transfer? Do we transfer one, or do we transfer two? Well, I can also tell you that 10 years ago, 80% of the time we would transfer two. Today in our program, 75% of the time we do a single embryo transfer, because in our program, our pregnancy rates are the same, essentially, transferring one versus two embryos. Looking at this national data, the live birth rate from 2015, single embryo transfer had a pregnancy rate of 52%. Double embryo transfer, meaning transferring two, had a pregnancy rate of 58%. Doesn't look that much higher, but it did achieve significance looking at this summary data. Now, what does significantly increase when you transfer two is the incidence of twins. And this is the kind of data I like because it's crystal clear. The twinning rate transferring one embryo is 2%. When transferring two embryos goes up to 31%. So we work actually very hard to minimize the chance of twins. So I know some of my patients want twins. We'll counsel them about the risk. But transferring two will significantly increase your chance of having twins. A twin pregnancy significantly increases your chance of preterm delivery. The chance of preterm delivery, this is from that same SART data set from 2015, with a single embryo transfer was 11.5%, and it goes up to nearly 26% with a double embryo transfer. So a twin pregnancy is high risk from the get-go. You have higher risk of miscarriage, you have higher risk of hypertension in pregnancy, diabetes in pregnancy, preterm labor and delivery, and fetal demise during pregnancy. So these are not minimal problems. It is a high-risk pregnancy from the start. So how do you have two babies at the same time with minimal risk of complications? Two surrogates with a single embryo transfer into each. And I'm doing more and more to this for my patients who want twins. Especially for a gay couple, they both want one of their embryos transferred. If you do a double embryo transfer into one surrogate and she gets pregnant, you won't know who the biological dad is until delivery and you do genetic testing. If you do one embryo transfer apiece into two surrogates, one surrogate's pregnant, one surrogate doesn't. The next month, the surrogate does another embryo transfer, you get pregnant, and you both have babies around the same time. So what's the downside of two surrogates? Maybe cost. Cost would be your initial reaction. But if you actually look at this, and this is a rather simplified analysis, if you look at the cost of one surrogate payment and agency fee is about $60,000. Well, if she has twins and the twins deliver early and they spend several weeks in the NICU, neonatal intensive care unit, your hospital bill is going to be at least $100,000.